Good evening, everyone. Thank you for joining. We're going to get started right at 7. So if you have any questions during the session, please raise your hand or you can put it in chat as well. I'll be monitoring the chat. But I'm going to let our presenter start off.
Hi, everybody. My name's Elena. I am out of Denver. So I'm a clinical educator for an acute team program that we have out in Denver in the metro area. We go to 8 hospitals. I've worked there for 13 years. And so we do HD, PD, CRRT, and plasmapheresis. So Christina kind of asked me to talk maybe about some acute stuff, and then we just threw some water treatment stuff in there as well to get kind of some review on the water treatment, since acute therapies are not going to be a huge portion of your test. As you can see there, it's just 5% of your test, but you'll have some basics understanding of plasmapheresis, and then there's definitely going to be some water questions on there. I do have both my certified dialysis and my certified nephrology nurse. I got those years ago. So I didn't find the test to be too bad. Uh, it was a little bit tricky though if you're not in acutes. So anyway, let's get started. Today, with water treatment is where we're going to start off. We're going to talk about the basics, the bacteria battle, the parameters, the monitoring system. We'll also talk about the basics of plasmapheresis and some autoimmune conditions. And then we'll have a general understanding of how, not who, how plasmapheresis works. So why is water treatment important? It's important for patient health. In fact, it's part of their prescription. Dialysate is 95% water. The purest possible water, the better the dialysis. Pure water lessens the risk of exposure across the dialyzer. So I actually knew some nurses that worked in dialysis before they treated the water. I don't know if anybody's ever talked to anybody about that, but it did make the patients really sick and they did not live very long back in those days. So I'm glad we figured that out. So there's different, where has our water been? Of course, there's groundwater and surface water. So the groundwater is going to have a lot of dirt and soil and different things that come out of it. That's all in our tap water. And in small amounts, that's not going to hurt us. So we have surface water here, contains varying degrees of silt, mud, dirt, debris, chemicals, metals, and toxins. We're thinking typically more organic stuff here, like bacteria, and algae. And then the groundwater is generally more inorganic minerals, salts, and chemicals. Drinking water is not dialysis water, as we know. I actually learned something recently when I was prepping for this is that drinking the purified dialysis water is actually not good for you at all. It would pull out all the minerals and everything out of your digestion, so it would actually really dehydrate you. So if anybody ever asks you if, oh, can I drink that water if it's so pure? The answer is no. Um, this here on the right, the picture is a multimedia filter. So as you know, there's all the dirt and mud and everything that's in our tap water. That has to get removed before it ever goes to the carbon tanks, or else it will block up the carbon tanks. So that's part that you may not see that's very important. Those filters get changed out typically every 90 days. Just like you would have in a hot tub or something, you have to get the actual sediment out of the water before it can actually be treated. And why do we care about this? Well, obviously it goes right to the patient. It could go through the dialyzer. So we have to make sure that those harmful things are removed from the water. Accumulation over time can absolutely reach toxic levels. Sometimes I like to ask little questions just to get feedback. There's not too many of us here, but has anybody ever seen chlorines hit the water and make patients sick? I haven't. I've heard a story about it, but nobody's seen that. I haven't either. I mean, we have a lot of safeties in place to prevent that from happening. So, the average population, we consume about 15 liters of water a week. Hemodialysis patients, however, are directly exposed to 400 liters of water a week. That's a cool thing that you can say to patients too to kind of help them understand why we have to treat that water. Especially in acutes, they're very aware of the water treatment because it's in their room. In the dialysis center, they may not be as aware with it being in the back room. The best temperature that you're going to have for RO water is 77 degrees Fahrenheit. It can't be too hot, shouldn't be too cold, or it doesn't operate properly. Um, Water softener, I'm not sure, but this could be on your test. The water softener, which prevents hardness in the water, is what removes calcium and magnesium. That always comes up for me with dialysis stuff. And then, of course, we have the reverse osmosis filtration. Big thing, carbon tanks, of course, you have to know this. Carbons remove chlorines. Every RO system has two carbon tanks. We have a primary and a secondary. Do you all have a process in your clinics or acutes for if the chlorine comes positive on the primary carbon? What do? You go to your secondary. If anybody has anything specific, you can yell it out. Um, we check ours every 30 minutes if we have to go to the backup carbon tank. So that's one of the reasons we have two carbon tanks is in case of a failure. Chlorines could kill patients. UV light mechanisms or ultrafilters helps to kill endotoxins. Endotoxins are like dead bacteria. So we're trying to kill both live bacteria and dead. The conductivity monitoring of ROs is like an electrical conduction. It's kind of hard to explain, but it correlates to the sodium level. So that's why we have to test the conductivity because if the conductivity is reading wrong or it's off, it could affect sodium levels in the water, which could affect your patient. Percent rejection rate should always be 90% or more. This just kind of lays out all the things we just talked about. All your RO systems, whether they're the central RO or the little portable ROs that we have in the acute setting, they're going to go through this multimedia filter, which catches debris, then onto the softener to remove calcium and magnesium, onto the carbon tanks to remove chlorines, and then the pre-filter is the last chance to protect the pump from debris. We have a booster pump, which is going to increase water pressure and then go through the RO. The ultrafilter is one of the last things which traps endotoxins and bacteria. And then finally, it's delivered to our machine. Has anybody ever seen this machine? The Phoenix? Yeah, we use that at some of our hospitals.
Yeah, I started on those machines when I was a tech a long time ago.
Oh, yeah. They discontinued them, by the way. So eventually we won't see them anymore. Excuse me. So, very important, carbon tanks remove chlorine. I think we all know that, but I'm sure that's going to be on your test. There's different regulating bodies that are going to be governing our water treatment. This is not by any kind of, it's not by the Joint Commission or anything. We have the Centers for Medicare and Medicaid, or CMS. We have AMI, very important Association for the Advancement of Medical Instrumentation. They put together water quality standards. We don't really go by anywhere I've worked, the ISO or the ANSI, but they do put out guidelines every year. We're mostly going by AMI and CMS. One of the things that just came out recently, I don't know if you all heard, the CDC released that the dialysis water drain boxes have been showing breakouts of bacteria. So one thing that you could take to your clinic is wiping down those drain boxes is very important to prevent outbreaks. Joint Commission is really focused on that this year too, just FYI. Um, Chlorine testing and verification. Everybody should at least flush your RO for 15 minutes before you check your chlorine. That gets the fresh water in there. So the stagnant water that's been in there since yesterday gets flushed out so that we have an accurate sample. Of course, we're doing that every 4 hours. AMI suggests equal to or less than 0.1 is acceptable. So it could be equal to per AMI. Now that might be different in your clinics, but just FYI, AMI says equal to is also acceptable. AMI also suggests having at least one analysis of tap water annually to check the mineral levels in your area. So for example, I'm in the Denver area. Golden and Denver have great water, but one of our areas, Thornton, has really bad water. They have high levels of calcium and sodium and things like that. So that could affect patients if the tap water is high enough in any of those electrolytes. The pre-filter, as I mentioned, gets out all the debris before it goes to the carbon tanks. So if we didn't have this, you'd be changing out your carbon tanks constantly, and you'd be at higher risk of having high chlorines if we didn't remove that debris before it hits the carbon tanks. The booster pump, it's recommended to have over 100 PSI. Definitely need good water pressure and good water temperature. Does anybody else work in acutes besides me? Okay. So you know all about water pressure and plumbing and temperature. I mean, sometimes we have to hook up to some really crazy stuff. Um, it's all regulated in the clinics. Usually they have a blending valve where they're getting exactly the right temperature that they need. We know all about osmosis as well. Everything goes from a high concentration of solutes to low. The different layers here in the RO membrane, they have been explained to me almost like cardboard, real thin layers of cardboard. So there's different layers in there that are gonna trap different things, primarily the carbon that's in our water or the chlorines that are in our water that can be so harmful. Stagnant water can grow bacteria. So on your manufacturer is going to be recommending all your HD machines need to be disinfected, typically Fresenius machines every 48 hours, Phoenix machines every 72. Basically, you just can't let these sit, right? If you let a machine sit for 8 days and then used it on a patient, you're very high likely to have some bacteria in there. We typically bleach and heat, but there's different ways of doing it depending on what type of machine you use. Just FYI as well, the portable ROs or the reverse osmosis, as well as the central RO. Central ROs get disinfected once a month, but portable ROs have to be disinfected every week as well. And portable ROs need to be run constantly to prevent stagnation and bacteria. Reverse osmosis, by law, have to be tested monthly for bacteria and endotoxins. Weekly disinfections on portables are recommended. Heat is preferred on the portable RO. Chemical sometimes is done, but it can obviously leave chemicals in there. This is just an example of an AAMI report that we have. All the different things we have to comply with. Now, these are not set by any particular regulating or any particular company. They're set by the regulating body CMS. Do you guys have these same levels? Are you aware of those levels? Bacteria, the CFUs, the offline level is 200. I don't know, but this part could be on your test because I think it's very important. And then the action level is 50 CFUs. CFU stands for colony forming units. So the max level, definitely machines offline is 200, and then we have to do something if it's 50. Endotoxins, remember that's our dead bacteria. Offline levels are 2 endotoxin units. Action level, 1 endotoxin unit. Here's a little pop-up practice question. The water softener removes what from the tap water? Anybody? Holler it out. Oh, I guess we have,
Venetia and VB said C.
yes, magnesium and calcium. Very good. Um, Water quality and testing, bacterial testing for cultures and endotoxins is done monthly on every piece of equipment. How do they do endotoxin test? It's called the LALs. So if you hear that term LAL, it stands, I guess I didn't put it on here. Oh, yeah, I did. Limulus amoebocyte lysate assay test. And they actually use the blood of a horseshoe crab to test for endotoxins. If there are high endotoxins in there, which is the dead bacteria, it can cause a pyrogenic reaction to the patient. So they could feel their throat closing or something like that. Do you guys know what the symptoms are of having high chlorines? Like if you had high chlorines in a patient, what they would be feeling or what we would be seeing? We could see hemolysis, right? From what I understand, they could start having nausea and vomiting initially, just a feeling of impending doom, a feeling of general unwell. Horseshoe crab blood saves lives. That's kind of a cool slide there. Okay, here's another pop-up practice question. The surveyor asked the charge nurse at the clinic what monthly tests are performed on all pieces of equipment to ensure safe water and safe equipment for patient use. So what's done every month? I can't see the chat, sorry. Maybe I can. Um,
C.
what? B?
C.
B. Okay, yes, you guys got it. And so I think when I worked in the clinic when I was first a new nurse, I always kind of just blew that kind of stuff off to the manager. But if you're going to get certified and really know what you're doing, you should absolutely know about all these different tests. You should know where to find them in your clinic if they ask you, where can you find the latest results? Who do you ask? So this is stuff I think you should know as a certified nurse. You should be very aware about cultures and endotoxins, annual AAMI tap water analysis. Um, you don't really need to worry about the water pressure multimedia filter function because that's on your morning checks. So what exactly does biomed do? Well, they do a lot. And I'm not a biomed, so I did the best I could on water stuff here, but they of course fix our equipment. They maintain records of the annual preventative maintenance on all machines. So every machine has to have an annual preventative maintenance or PM, repairs, disinfection schedule, weekly and monthly disinfects to keep machines safe, monthly cultures and endotoxins. Elevated CFUs or EUs require additional disinfects and a recollection, and they help keep our patients safe. So that's just kind of a little basic Water 101 review. Hopefully you guys all knew all that, but any questions or thoughts? Okay. So we'll move on to the plasmapheresis. This part might take a little bit longer, depending on how into it we get. So understanding therapeutic plasma exchange or TPE. We call it TPE where I work, but you may also hear it referred to as PLEX, which is plasma exchange, apheresis, or just plasma exchange. Even different doctors, they'll come in the room and they'll say, "Oh, when's the plex happening?" or "When's the apheresis happening?" or we call it TPE. So there's all these different terminologies you can use. They all pretty much refer to the same thing. Why do we do this as dialysis nurses? Because it's pretty much exactly just like dialysis, only a different filter and a different purpose. We're using the same lines. Um, we're very familiar with the extracorporeal circuit therapy. We're familiar with catheters, close monitoring. So that's why it's best that dialysis nurses perform this, even though there's no actual kidney problems usually going on with these patients. Do you guys know of any other extracorporeal circuit therapies besides dialysis and plasmapheresis? Uh, I always think of ECMO.
LDL.
LDL, liver dialysis?
No, we do LDL treatments at UC Health. It's Venetia, help me. I'm brain dead right now.
That's all right. Yeah, that's cool. Um, I know there's different types of apheresis that we'll talk about too, like leukophoresis and red blood cell reduction therapies and stuff. And then another extracorporeal circuit therapy is something called ECMO, which is where they oxygenate your blood and basically take the place of the heart and lungs. They do that in open heart surgeries. You have to be a perfusionist in order to perform ECMO. So it's a high level degree and a high level of training. We actually connect our CRRT to the ECMO at some of our hospitals. So it's kind of an intense situation, but what we do is actually pretty cool with the extracorporeal circuit therapies. So today we're going to be talking about TPE foundations, the purpose and rationale of TPE. How do we do it? The procedure basics, medications that are used during this procedure, complications, special considerations. Whoops, didn't want to
Elaine,
go.
can I ask you a question?
Yeah, uh-huh.
So I learned recently that university does not put their ECMO in line with their CRRT,
hmm
which surprised me because I did acutes and we would do that often. Do you know why they're, I didn't really kind of dig into why they do not follow that practice.
Yeah, we've gone back and forth on this. I think it's a patient safety, and depending on who the medical director is, our medical director wanted our own dedicated line that was separate from the ECMO because he didn't feel confident that the ICU nurses could monitor both the ECMO and the CRT if it was connected together.
Right.
So I think it could be just a hospital or a physician preference. Um, there's really no reason why we can't connect it together as long as there's a good policy in place and a good system, right? Where everybody's had adequate training and everybody understands what they're supposed to do.
Got
So,
it. Thank you.
yeah, I can see it going both ways. We've had to do it though because you can't always get two lines in a really sick patient like that.
Mhm.
So the machines here, if you haven't ever seen these or used these, the green one is called the Prisma Flex. This machine we use for CRRT as well as plasmapheresis. And then the new machine to the left of it is actually the new type of Prismaflex called the Prismax. It just came out in the last couple of years. And then the one up top here, I think Fresenius might use that. And I had the name of it, but now I'm blanking on it. Does anybody know the name of that one on the top right? I think is it Amicus? I don't know. Anyway, any of these three machines can do plasmapheresis. The next stage machine can also do plasmapheresis as well. Here's some basics here that we're going to talk about with what is plasma exchange and how does it work. We're basically separating out the plasma from patient's whole blood to remove it. I do have kind of a cool picture down here of somebody that had hypertriglyceridemia or really fatty high triglyceride blood that we had to separate their plasma out, and that's what it looked like. It's very milky, and so that's not normal. So it was a good thing we were removing that. You can use, there's two methods of TPE, therapeutic plasma exchange. You can use a filter or a centrifuge. So there's two different ways to do this. At my facility, we use the TPE 2000 filter, which attaches to the Prismaflex. This type of filter can only remove plasma, so it's not truly apheresis. It can't remove other parts or components of the blood. It only removes the plasma. If somebody needs a white blood cell reduction therapy, they have to go to a special hospital that has a centrifugal type of plasmapheresis. So we use a filter at my program rather than centrifuge. Plasma is separated in the filter and then removed in something called the effluent, which is what we see down there on the right. Post-filter replacement fluid is then going into the air chamber at the exact same rate that the plasma is being removed from the patient. So it's a 1 ml to 1 ml. As we remove 1 ml of plasma from the patient, 1 ml of albumin is going in at the same rate, or FFP. And so in theory, the patient's body shouldn't notice that big difference. The TPE filter fibers are very large, a lot bigger than the hemodialysis filter. The apheresis machine uses a centrifugal technique, which basically means it spins the blood and separates out the plasma or other components like lipids or white blood cells. So it's a cell separator, like what they would use down in the lab. Sorry, I like to put my little camping pictures and things up. So the definition of plasmapheresis is it's a procedure that removes and replaces a patient's blood plasma to treat certain diseases, removal of a pathogenic substance. It was invented in 1914, introduced to humans in 1926, and then it's been a little bit more standard since 1952, where they did the first hyperviscosity syndrome. I personally, when I first started in nephrology, I guess it's been 16 years now, it seems like it's gotten more common in my experience, but I don't know, maybe that's just me. We talked about apheresis versus TPE. So there are other things that can separate out besides just the plasma. So in all plasmapheresis treatments, we have to have a continuous calcium drip going. Why do we need a calcium drip going during a plasmapheresis? Most programs are going to be using citrate anticoagulation rather than heparin. So the way citrate anticoagulation works is it goes in pre-filter and pulls the calcium out of the blood. By taking the calcium out of the blood, it blocks the clotting cascade. So the blood cannot clot without calcium. So by using citrate, we're taking the calcium out of the blood in order to prevent clotting, and then we have to replace the calcium during the therapy. Even if you're not using citrate anticoagulation, there's citrate in the fresh frozen plasma. So you're going to be losing calcium either way. Even if you're not using any type of citrate, you have to have a calcium replacement going during a plasmapheresis treatment. We use a bear hugger to keep the patient's blood warm. There could be different types of machines, but we have to use a bear hugger because room temperature fluids going into the body at such a high rate can be up to 2 liters an hour or higher, can actually decrease the body temp significantly. So we have to try to keep the patient's body temp at a normal level, or they're going to be really, really symptomatic. We have all our patients on telemetry during plasmapheresis. Why do we need that? Well, we're messing with their electrolytes, right? We're messing with their calcium. Heart rate changes can be an early indicator of hypocalcemia. We could also see other things too, just if they're having a reaction or something. So they have to be on telemetry. If we weren't using citrate anticoagulation, do I still need calcium? Yes. In the rare occasion, at least in our program, where if we're not using citrate for some reason, we have been running out, you'll need a little bit of calcium because you get calcium loss with plasma removal. What types of replacements are we using for plasmapheresis? We have 3 different types. So as we're pulling the plasma out of their body, what are we replacing it with? We have 3 choices. We have albumin 5%, normal saline, or fresh frozen plasma, which is a blood product, right? Albumin 5%, I would say, is the most common used. Note that it's not the 25% that's used for hemodialysis when we get low blood pressure in acute setting. So this is a less concentrated type of albumin. This gives us larger volumes. Typically, it comes in a 500 ml bottle. This is used in non-coagulopathic diseases such as myasthenia gravis, multiple sclerosis, or Guillain-Barré. Normal saline can be used in combination with albumin 5%. I don't really like using saline. Can you imagine taking all the plasma out of your blood and just replacing it with saline? It does not seem like a good idea, right? So we've kind of gotten away from that practice in recent years, and a lot of the younger doctors don't use any normal saline at all. But if you are using normal saline as a replacement for plasma, you have to use it in combination with something else. You can't just use saline. In our practice, it should be typically no more than 30% of the total exchange. We used to do 50% albumin, 50% normal saline, and patients got really symptomatic with that. Their pressures dropped. Some of them even almost coded. When used as a plasma replacement, blood pressure can drop. We never start with normal saline or end with normal saline for that reason. And then our fresh frozen plasma is going to be used, it's reserved for conditions that are coagulopathic, such as TTP or vasculitis, maybe Goodpasture's. I do have those conditions that we'll talk about a little bit more coming up. So you could be giving 10 to 25 units of blood in a matter of 3 hours during a plasmapheresis session. So those units are going in, anywhere from 5 to 10 minutes. So it's really, you have to be monitoring them really, really closely. Documentation is important. Signs and symptoms of transfusion reaction, very important. Early versus late signs, things like that. Sorry, some of these are for my nurses, so I thought I took out all the stuff, but maybe not. So let's talk about some of the conditions here that we're going to be treating. We're treating autoimmune diseases, right? Does anything pop up? Have you guys had any patients at your chronic clinics that ended up with ESRD from an autoimmune? Does anything come to mind?
Lupus.
What about that? They used to call it Wagner's granulomatosis or vasculitis. Anybody seen that one?
Mhm.
Lupus, maybe. So there are some autoimmunes that do affect the kidneys, but a lot of them don't. So we'll kind of go through the most common conditions that are treated with plasma exchange, and noting that these are for severe flares. So your typical, if you have people that that have MS or something, most of them are never going to have plasma exchange, right? This is for people that failed steroids, failed IVIG, traditional treatments have not worked for them, and they had a severe flare, putting them potentially in the ICU. And plasma exchange is kind of a last resort to get these people out of this extreme flare. So we're looking at myasthenia gravis, multiple sclerosis, Guillain-Barré, RPGN, which is rapidly progressive glomerular nephritis, TTP, that's a scary one, thrombocytopenic purpura. We have a patient right now with that. NMO, neuromyelitis optica, where you start to go blind. HUS, hemolytic uremic syndrome, Goodpasture's. Vasculitis, formerly known as Wagner's granulomatosis, might also be seen as ANCA vasculitis. Hypertriglyceridemia, multiple myeloma, transplant rejection. I don't ever get to see that because I don't work at a transplant center. APL, which is antiphospholipid syndrome. Scleroderma, any autoimmune demyelinating disease, encephalopathy of unknown cause. That one's really hard because it's kind of like a Hail Mary for those patients with encephalopathy that's not getting better. And I've never seen that work, so that one's kind of sad. Stiff person syndrome, which I heard that Celine Dion has that. Yeah, I'd heard that on the news. Lupus, other conditions which I haven't really seen, but I see IBS on there, malaria, sickle cell. I haven't ever had to do plasma exchange for any of those, but it's possible. We'll talk about the most common ones. Let me move this one. Okay, there we go. How does TPE treat autoimmune conditions? It removes the patient's plasma and along with it, the disease-causing agent attached that triggers the symptoms. So normal plasma has cytoplasm, nucleus, normally light yellow or straw colored. What lives in our plasma? We have water, salt, enzymes, antibodies, very important, clotting factors, and the proteins and albumin and fibrinogen. Why do we remove plasma to treat these diseases? We're removing large amounts of the disease-causing agents that are attacking the body, causing the symptoms. So when steroids aren't enough and IVIG is not enough, and they've got so many antibodies in their bloodstream, we've got to do something to get that load out of their system, right? It's just overwhelming. No amount of drugs that we throw at them is going to suppress their immune system enough to get them out of this flare. So we actually go in and we filter out the antibodies to give them a fighting chance. This is a little plasma cell here. So our antibodies live in the plasma cell. That kind of helps. Usually, if I explain it that way, patients will understand it. We have to get those antibodies out. That's the way that we get them better. Uh, Blood, if you see like when you send your blood off to the lab, it kind of separates. That yellow part is your plasma. 55% of your blood is made of plasma. How does normal immunity work? This is kind of a review for me too, because I haven't taught this class in a while, but an antigen is a foreign material that comes in and triggers the immune system. It can be bacterial, viral, or a form of tumor or cancer. Antigens then stimulate the production of antibodies, also known as immunoglobulins, which bind to antigens and neutralize them. So you've seen on maybe on your patient's blood work like IgG, IgM, IgE. Those are all immunoglobulins or types of antibodies. So when your doctors are ordering all these tests and everything, they're looking at different types of antibodies that might indicate that there's a problem. Lymphocytes are a type of white blood cell consisting of B and T cells. The cells work together to activate a healthy immune response. B cells become antibodies, and then T cells directly eliminate antigens. So that's a healthy immune system. Well, what happens in an autoimmune disease? Immune system forms antibodies to their own antigens. So it thinks that the antigens in your own body that are good are bad antigens. And so it starts to try to attack them. This causes inflammation and tissue disease. Let me see if this little diagram here, if there's anything helpful on that. Basically, it's your body attacking itself, right? I like that guy because I don't know, he always makes me laugh, but Um, a lot of us, this is not really, well, this is out of our wheelhouse. We're nephrology nurses, what are we even talking about here? But all these different antibodies can cause autoimmune disorders, IgG, IgE, IgD, IgM, IgA. And that just kind of differentiates the different types of immune response that we're having. Okay, so myasthenia gravis, definitely a really common one that we see. This is an autoimmune disease that disrupts communication between nerve cells and muscles. So it typically presents as rapid weakness and fatigue. MS, very common, of course. I think we probably all know somebody with MS. It's an autoimmune system. The autoimmune immune system eats away at the myelin sheath that covers the brain and spinal cord. So it can present as vision loss, pain, fatigue, or impaired coordination. The treatments for MS have gotten a lot better in recent years, so we don't see as many MS patients as we used to. Guillain-Barré, this sometimes happens after a vaccine. It attacks the peripheral nerve cells. It may present as weakness and tingling in the feet and legs that spreads to the upper body, and paralysis may occur. So whenever I've seen Guillain-Barré, once it gets up to the hips and it starts to get to the diaphragm, that's when we come in with plasmapheresis because that patient is going to stop breathing and they have to get put on the ventilator. NMO is neuromyelitis optica, attaches to the optic nerve, and that can present as visual loss or color blindness completely if it's not treated. RPGN, rapid loss of kidney function. That's rapidly progressive glomerular nephritis. I haven't seen real good outcomes with these folks. They usually end up progressing to ESRD. If they aren't treated though, they'll probably succumb to death within months. Vasculitis is an autoimmune disease, inflammation of the blood vessels. The immune system attacks your own tissues. Hypertriglyceridemia is the fat in the blood. A lot of times this will present as like an acute pancreatitis or a diabetic ketoacidosis, hardening of the arteries with increased risk for stroke, heart attack, and heart disease. It has to be pretty bad for us to be doing plasmapheresis for hypertriglyceridemia. And then we have TTP, a very, very scary disease, could be fatal within 48 hours if not treated. Blood disorder resulting in blood clots forming in the small vessels throughout the body, resulting in low platelets, low red blood cells, and then sometimes kidney, heart, and brain dysfunction. So the lowest I've ever seen was hemoglobin was 3, platelet count was 4. So those people require obviously immediate emergent plasmapheresis. Multiple myeloma is a type of cancer that lives in the plasma. So we can actually remove the plasma and help to give them a chance to fight that multiple myeloma. Encephalopathy, um, again, not great data on that one, but we do it. HUS is hemolytic uremic syndrome, a blood disorder characterized by low red blood cell count, acute kidney injury, and low platelets. And there's our resources there. Here's a question, and I got this directly from the practice test. Which of the following is an appropriate replacement fluid to use during TPE when treating severe TTP? That's the one that attacks your red blood cells and platelets, right? So what would you use as a replacement fluid for this patient?
See?
C. Yep. So on that patient, because they're breaking down their own red blood cells and platelets, they need actual blood products as their replacement rather than just albumin or saline or something, right? And we never use mannitol or cryo. So that was directly from your practice test. These are just all the things that we need when we do a procedure. We need all these different orders, all the daily labs, different rates and different things that we use. You guys don't need to know that too much. The different medications that we use, again, we're using a citrate anticoagulation. We're using albumin 5% as a replacement potentially. We can use a little bit of saline. We need a continuous calcium drip. And then we sometimes use FFP or fresh frozen plasma if they have a type of clotting disorder. There's some conjunct medications that the patient will be on in addition to receiving plasma exchange. They could be getting Cablivy, IVIG, Solumedrol, rituximab, which is a chemo drug that a lot of these patients are on now that works really great for them, and prednisone. So two different types of steroids. Usually they're on a lot of stuff. I mean, they're in a really severe flare if they're getting plasmapheresis. This Cablivy, I don't know if anybody's seen that in their practice, but it's a highly, highly expensive medication that treats TTP immediately. If you want to look it up later, it's actually really interesting. I've given it twice, and both the patients that we gave it to needed one plasmapheresis, and then they got better. They needed no more. It was amazing. But unfortunately, because of the cost and insurance, I don't know if we'll see that one very often. What does a nurse need to know? How's your nursing assessment during plasmapheresis? Pre-treatment, we're looking at all the normal stuff that we look at typically with any dialysis, or should be. Cardiovascular, heart rate, blood pressure. We put them on tele, heart sounds, pulses. We like to do a little bit of a good neuro assessment because we need to assess them for hypocalcemia. So I always like to ask them if do you have any numbness and tingling right now? What's their orientation level? Do they have a headache? How are their sensations? Their respiratory status, shortness of breath, lung sounds. Do they make urine? What does their BMP look like? If their electrolytes are all out of balance, then we might have a problem. Eyes and nose, edema. How's their skin? How are you going to know that they're having a transfusion reaction if you don't look at their skin at baseline? Some people have, little red dots and different things, and how will you know that that's a normal thing for them versus something new? A lot of these folks are going to have some anxiety related to this treatment. It's very scary. So I always think about that too and just trying to calm them down. We look at their labs, daily CBCs, BMP, ionized calcium, PT-INR, and the vascular access and consent. During the treatment, we're doing blood pressures every 15 minutes. We're looking for signs and symptoms of hypocalcemia, transfusion reactions, and hypotension are our most common complications there. And then post-treatment, how are their vitals? Do they have any numbness and tingling? And then we in our practice do a 1 hour post-treatment ionized calcium to make sure that they didn't drop their calcium levels too low. What are the signs and symptoms of hypocalcemia, by the way? I always make people answer questions. I'm sorry, but you guys are all on mute. Um, the most common one, I don't know if anybody,
Um, tingling, numbness, chest pain is
yep, yep.
in the chat.
Most common, of course, is that, what's that? What else?
That was the answers in the chat.
Yeah, so the most common signs and symptoms of hypocalcemia is going to be your numbness and tingling. Typically, it'll start in the lips or the fingers. If somebody feels that, that's what that could be. And then we could see telemetry changes, chest pain, headaches, and that can be really a dangerous side effect. Patient education, of course, is important, always important for everything. And then some complications you can see. Here's our signs and symptoms: hypocalcemia, numbness, tingling in the lips, muscle spasm, seizures, or confusion. We could still have air in blood, right? Just like we do with HD, we want to prevent that. Transfusion reaction, hives, anaphylaxis. Mild reaction could include itching, urticaria, which sometimes we still keep going because we're giving a unit of blood every 5 minutes. So by the time we notice somebody has a little bit of itchiness, that blood's already in. So we'll give them a little bit of Benadryl or a steroid, and we'll keep going after we notify the physician. They can have chest pain or impending doom. If I did have somebody once tell me they felt like their throat was starting to close up, and I was like, okay, we're done. And that was the end of that. And they did fine. Hypothermia can happen, coagulopathy, right? Because coagulopathic components live in the plasma, and as we're removing plasma, they're going to get depletion. So that is going to happen over time, and they can get itching from the medications or the FFP. They can have electrolyte derangements, allergic reactions, hypotension if you're using normal saline as your replacement. Their bodies don't react very well to that. They can have anxiety, which sometimes presents as like something scary, right? I once had a patient tell me that her tongue felt fuzzy, and I was like, I don't like that. I don't exactly know what that means, but she ended up being fine. But sometimes these symptoms that they talk about can be very vague and very hard to understand. Um, we do have an ACE inhibitor contraindication. I don't know if you knew that ACE inhibitors actually can react with albumin negatively. So we're not, I mean, in the chronic clinics, you're not giving albumin, but you might look that up if you're interested. Any patient that's on an ACE inhibitor probably doesn't have low blood pressure, so they're probably not getting albumin, but typically ACE inhibitors have to be discontinued 24 hours prior to plasmapheresis. They've also been known to cause a bradykinin release because they interact with our filters. Here's an example of a hypertriglyceridemia that we did years ago. This guy his potassium was 9.1. He had a diabetic ketoacidosis with hypertriglyceridemia and acute kidney injury. Previously healthy guy, he was in his 30s. So first we had to do an emergent HD on him to get his potassium down. And he ended up coding twice during the HD. Got him stabilized. We were able to finish plasmapheresis, which took us about 9 hours to do this because of how fatty his plasma was. We kept clotting our filters. And then we put him on CRT because he was so sick. And he ended up walking out of the hospital. So that's a case that I'll personally never forget. Okay, that's it. Questions?
Thank you for such a great presentation. Does anyone have any questions?
The information about the ACE inhibitors not within 24 hours of pheresis, that's new information for me. I haven't done pheresis for a couple of years, but it's just scattered here and there. But I did not know that. When did that
Now,
become?
that could be something that it's specifically known that it could be an interaction with the TPE 2000 filter because of there's like an AN69 component in there that reacts with ACE inhibitors. But then upon doing further research and talking with Matt Lawson is our Vantive representative that we use from Baxter, and he's a plasmapheresis kind of expert. He also found me a bunch of articles that said that ACE inhibitors can react with albumin. So in our practice, if somebody has received an ACE inhibitor in the last 24 hours, we actually cancel the treatment because their reaction can be that
Wow.
severe. It may not be like that in other places. If you're using a centrifugal TPE, it might not be as big of a concern, but it can react. And we recently had a sort of a case study happen on, have you seen these like ACE inhibitor combo drugs? It's not like a lisinopril or whatever, but it's like a combo drug of something and something else, and it has a little bit of an ACE inhibitor in it. And we found that this guy was on that, but nobody really realized that that was a type of ACE inhibitor, and he had a significant reaction.
Wow. Interesting. I'm going to be reading about that. Thank you.
Yeah, I can try to find the information that I have on that and maybe share it with Christina when I'm back in the office tomorrow.
Elaine, good evening.
Mm-hmm.
I have a
Hi.
question regarding that monthly lab for water. What is that? I missed that part there.
Are you talking about the monthly cultures and endotoxins?
Yes.
Yeah, so that is regulated by CMS. It has to be done on every piece of equipment to ensure that there's not too high levels of alive or dead bacteria. The cultures are the alive bacteria, and the endotoxins are the dead bacteria. So,
Mm.
per law, every machine has to have results of cultures and endotoxins at least once a month. It can be any time during the month. Like you could do it on July 2nd, and then the next month you could do it on August 15th, but it has to be done at least once per month.
Okay, thank you.
Mhm.
This is KP. I have a question. I accidentally just kind of stumbled. I think I got an email a couple of days ago about this Zoom meeting, and so I joined tonight for the first time, and I wish I knew about this much sooner. This is really awesome because I am preparing to take my CNN.
Yeah.
The question I have about this is this a series that's going to, is this like a session and it will end at some point, or is this a repeating thing that?
Christina can answer that one. She's in charge.
Hi, KP. Actually, we started at the beginning, or yeah, the beginning of July. All the Zoom meetings, have been recorded, and the the meetings are on YouTube. And the plan is for all of us to hopefully take the test by the end of this year. So I'm going to have Zoom meetings every Wednesday until the end of December, is the plan.
Yes, I have it in my calendar now, so I'll be here from now on, and I'll go back and so I can catch the previous sessions on YouTube.
Yes, yes. And we finish this meeting, I submit it to on the Anna forum, and then so everyone can have, and anyone who wants to take the test is welcome. They don't have to be an Anna member, but that's the only way I know how
Okay.
to get it out, and then everyone can share it. Whoever wants to be part of it. This is, Anna members only. That's not. It's for whoever wants to take the CNN or CDN test.
Okay. What do I search for on YouTube to find it?
I will, well, you can look under my name, Christina Bomber. That's where I've kind of put all the videos. But if you want to
Okay.
email me too, I can also send you the video links and the slides and stuff as well from all the
Well, that
previous
would be awesome.
classes. Okay. Yeah, just send me an email. I'll put my email in the chat, so
All right.
if anyone needs it, they have it.
All right. Thank you so much. I'm sending it now.
Thank you,
We have
Elena. This is
we
really
have several
Yeah.
presenters coming up next month and next few weeks as well. So
And if you run out of presenters, I've got plenty of stuff to talk about. I've got a pretty cool acute complications and CRT presentations that I do on the regular.
Okay. Well, Elena, you're putting yourself in a, I might just be
I
reaching
know.
out to you.
That's all right. As an educator, that's my job. So if you run out of things to talk about, just let me know.
All right. Well, I appreciate that.
Our entire team's goal is to get CNN certified within the next year. So I'm going to be sending out to everyone to get on this. I think everybody would benefit, and I think they'd really enjoy this. I've refreshed a lot of stuff on as far as the water machines and things like that that I haven't had to mess with. We use the Tableau hemodialysis machine now and the Spectra Optia plasma machine. And I kind of forgot about a bunch of that stuff since we went to Tableau 4 years ago.
Yeah, and I think some of that stuff will definitely be on the test with some of the Water 101 stuff, you know. All right. Nice to meet you all. Thank you for coming and participating in
Thank
my
you so much
question.
again. We appreciate you very, very much.
Yeah. Thanks, everybody. Take care.
And again, everyone, I will send the videos and the slides out tonight. And if you have any questions or concerns, please email me. Like I said, we have a presenter almost every Wednesday now through the next couple of months. So if you have anything you would like to present or ideas, please reach out to me and I'll be more than glad to get somebody to present or create it or reach out to Elena again. So, thank you all for joining. Have a wonderful night and we'll talk to you soon.